Good evening, everyone. Warm greetings from Dubai. On behalf of United Optometrist Forum, I am delighted to welcome all of you in today's webinar, Shaping the Future of Myopia Management, Latest Advances in Myopia Control, Integrating Optical and Pharmacological Strategies. We are honored to host this educational event from Dubai, and it's wonderful to have participants joining us from across the Middle East and around the world. First and foremost, I would like to extend our sincere appreciation and gratitude to ZEISS Vision Care for this valuable support and collaboration in making this webinar possible. We are truly overwhelmed by the responses, with more than 850 plus registration received for this evening program. Thank you for your enthusiasm and commitment to advancing myopia management. I am also pleased to announce that this webinar has been accredited with 2 DHA CME points. But kindly note that in accordance with the Dubai Health Authority policy, participant must attend a minimum of 1 hour of the webinar to be eligible for CME credits. Certificates and CME points will be processed and delivered within 21 working days following the event. Throughout the webinar, if you have any questions, please type them in the chat box and we will do our best to address them during the panel discussion at the end of the session. Without further ado, it is my great pleasure to introduce our first speaker of the evening, Dr. Shatia Al-Farehi, Division Head of Pediatric Ophthalmology at King Abdullah Specialist Children's Hospital, Ministry of National Guard, Health Affairs, Riyadh, Kingdom of Saudi Arabia. She will be presenting on the rising impact of environment on myopia development. Over to you, Doctor.
Thank you very much. Thank you, ZEISS, for this opportunity to be amongst you here today and present my topic. All right, I hope you can see my slide. So the title of my presentation is The Rising Impact of Environment on Myopia Developing Change in Environmental Factors, Pre-Myopia, Myopia Threat and its Management. So in recent decades, myopia has demonstrated an increased rise in prevalence and earlier age at onset, with long-term data on the prevalence of myopia, primarily from the Far East. However, there are so many different publications from all over the world describing an increased rise in myopia all over, especially in the Far East and Asian population. So our myopic surge and the uprise in myopia in this regular genetic framework that has not changed over the year, of course. So there must be something that has changed, and that could be attributed to the change in environment and our lifestyle, more outdoor decrease in our outdoor activities, excessive engagement in near work, and also visual, environmental, and circadian rhythm changes that have influence. And the major influence of COVID-19 with increased surge in myopia after COVID-19 as well. So there are many studies looking at environmental factors, looking at what actually is meaningful and what should we keep an eye on and what has strong evidence in myopia surge. So the ones that have been shown to be strongly related to that increase in myopia is the time spent outdoor, light intensity levels, and also near work. There are other factors including diet, sleep and circadian rhythms, but they have possible or weaker association with the development of myopia. So what is vision? How does vision develop, and how does one develop myopia? Well, you might already know that children are not born with sharp vision. This is something like a milestone that has to develop over time, starting from 6 months of age, where they can see 2100, till about 6 years of age, where they start to see 20/20. So that milestone change goes hand in hand with an ocular and biometrical change. Newborns are born with axial length of 16 millimeter, and then their eyes elongate to about 24 millimeter in adults, and that growth is very crucial in the development of emmetropia, or reaching the emmetropic state, which occurs very rapidly in the first 2 to 3 years of life. And it follows a bi-exponential pattern where most people are actually emmetrope or zero, and then there are some people who fall within that range. So newborns are not emmetropes. Newborns are naturally or normally hyperopes. This is not a refractive error. This is normal newborn status. 70% are hyperopes, and 20% of those newborns have astigmatism. Only a very few have emmetropia and also myopia right there. So this is a normal, natural thing that we have. So how do we reach emmetropization or zero status? It's a process where eye automatically adjusts refraction towards emmetropia, and it begins at birth with the axial elongation of the eye and the flattening of the cornea and the lens as well. And they go hand in hand, where these changes in the anatomy reaches emmetropia, and astigmatism resolves spontaneously. And that change most significantly occurs in the first 12 to 18 months of life, with a very rapid surge up here, and then it plateaus thereafter. So this is a physiological mechanism that starts at birth with hyperopia, along with the corneal flattening, lens thinning, and axial elongation, where we reach emmetropia. So, however, when things overshoot and axial elongation continues, this is when problem occurs and myopia develops, and our hyperopic reserve depletes. So this is another terminology that I want you to be familiar with, which is hyperopic reserve. And that's something that we will be talking a lot about in the near future. And you're going to be hearing a lot about hyperopic reserve on hyperopic reserve depletion. So what is hyperopic reserve? What's the definition of hyperopic reserve? It's a physiological hyperopia that buffers against myopia development to emmetropization, which is the amount of latent hyperopia before one gets myopia. So the higher hyperopic reserve, the less likely you will develop myopia. So it's a critical biomarker for myopia onset. So normally, when a child is born, they're normally, as we mentioned, hyperope. It's about 2 to 3 present diopters of hyperopia. And as axial elongation takes over, that hyperopia or the hyperopic reserve goes down till you reach about 16 years of age, where you're slightly myopic by this age. And that's a normal process. This is all normative data. So what is concerning? When should you be concerned? What are the thresholds? Well, the thresholds are universal thresholds, is 1.5 diopters at any given age, regardless of age or gender. If you have a patient with a spherical equivalent of 1.5 diopters, then this might trigger you that he is actually having a low reserve, or he might get myopia. And the higher the likelihood is by the lesser number, the higher the hazard. So in children, you want to see 1.5. Anything below than that, depending on age, will trigger you that this patient might be developing or going to develop myopia in the near future. So a spherical equivalent of half diopter to 0 predicts 40% chance of developing myopia in 2 years' time. Whereas if you have +2 hyperopia, your chances of developing myopia in 2 years goes way down to 3%. And that rapid reserve loss is age dependent as well, and it indicates accelerated risk. There are many population-based studies talking about hyperopic reserve and actually checking the hyperopic deficiency in many ethnic groups, especially in Chinese guidelines, where they have indicated that spherical equivalent of less than 1 diopter between ages 6 to 8 puts you at a higher risk. There's other recent publication from US, which is a multi-ethnic study showing that if you have less than 0.75 diopter at age 6, this signals the risk, and it has a decline, and this declines with age as well. So is this clinically significant? Yes, you should look for it, especially if you have a child less than 0.5 diopters by 6 years of age. This might indicate that he has already depleted his hyperopic reserve, and this reserve is going to push him into myopia very soon and premature exhaustion, given other factors as well. So what is premyopia? When should we think of premyopia? What is the definition of premyopia? This is a state where we don't want to reach. We want to actually trigger patients even before reaching that state, before depleting their hyperopic reserve and reaching premyopia. So premyopia, by definition, is the refractive state of less than 0.75 at age 6, and it's influenced by many factors, including axial length, parental history, ethnicity, and limited outdoor activity, high near work, and high ACI ratio. And it tells you that this child has a high risk of onset of myopia. The most important anatomical factor that influences premyopia and the shift towards myopia is axial elongation. Also, other factors that play a role is scleral stiffness, that reduced scleral stiffness, peripheral steepening of the cornea also plays a role, but the major factor that you should keep an eye on is axial elongation. So if you want to remember one number from everything that I said, 1.5 diopter of spherical equivalent in any given age or gender. This is the number that you want to see. I don't want to see a child with less than 1.5 diopters of hyperopic reserve. So we want to be able to know when we need to intervene, when intervention is warranted. So there are myopic conversion risk by a reserve level for each age group, and for each age group, you can actually know what is the chances of developing myopia. So as I mentioned, if you have more myopic shift, -0.5 to 0 diopter, then you have likelihood of developing myopia of 40%. Whereas if you have a +2 refraction, you have 3.3% myopia incidence. So what is the current terminology? How do we classify myopia? What is the proposed set of standards and clinical epidemiological studies, where the current consensus threshold values define myopia as spherical equivalent of less than half diopter, and high myopia is spherical equivalent of worse than 6 diopters. And pathological myopia is a proposed terminology or a categorical term to describe adverse structural complications of myopia. So what should we monitor? What are the things that we have to keep an eye on? What should we establish? And what is the common thing that we have to look at and personalize it by patient, and to control myopia and reserve levels? What are the things we should look at in school-based ophthalmological outreach programs to be able to do meaningful changes in myopia worldwide? Well, prevention strategy and outdoor activity are very well studied, and the recommended amount of outdoor activity is more than 2 hours per day web and continuous for 15 to 40 minutes bouts of outdoor activity is recommended. And this is effective actually when you have a good reserve. When you are already pre-myopic and you have depleted all of your reserve, these are not meaningful changes. There are so many studies talking about treatment of pre-myopes. So we want to be able to treat them before the ship sails. Are there going to be key clinical points, or hyperopic reserve is a critical predictor? Can we use this predictor as a term that we're going to be talking about in the near future, just like what they have in pre-diabetics, where they have glucose level charts, where we tell the patient, well, you're most likely going to develop diabetes in the near future? Are we going to have pre-myopia levels where we can actually chart those patients and tell them where do they stand in the risk of developing myopia in the near future? Are we going to be able to do risk assessment and change those risks depending on refractive levels that we have? So currently, reducing the rate of progression is a central goal of myopia research. However, preventing the onset of myopia or even getting myopia is an even more valuable target that we all should be looking at. So what is the incidence of presbyopia? It's quite high, 28%. What influences the development from presbyopia to myopia? What will make that patient even more at high risk? And I can tell him with confidence that we should intervene. Things should improve. We should actually do some meaningful therapy. Well, parental myopia is something that we look at, and it's a very important contributing factor: visual environment, binocular vision, and current refraction and biometry. So having one parent increases your risk threefold, while having two parents actually quadruplets that risk. Binocular vision assessment, when you have high ACA ratio, it puts that child at risk 20 times more, and accommodative lag as well as intermittent exotropes. There are other newer terms and newer numbers that we will be using in the near future, including spherical equivalent, axial length. This is something that we have talked about. But there are newer terminologies, which I will explain to make you more familiar with: the axial length CR ratio and the subfoveal choroidal thickness. So the ALCR ratio is actually a ratio of axial length in millimeter by mean corneal curvature in millimeters, meaning that the more axial length, the longer the eye, the higher likelihood that you will develop myopia. So if we take a 24 millimeters divided by 7.8, which is the corneal curvature in millimeter, this gives you the number 3 right here. Anything above 3, meaning you have a larger axial length or a longer axial length, puts you at a higher risk. 2.9 or less is what you want to see. What's the subfoveal choroidal thickness? Well, the choroidal thickness measured by OCT, it depends on age. However, if you have anything less than 3.3 millimeter, that means you have a large globe which is stretched, and that puts you at high risk of developing myopia. So this is a significant negative correlation of the subfoveal corneal thickness influenced by axial length. So this is something that we will be looking at, measuring and monitoring with a lot of therapy, and they're already using this number in measuring red light therapy as well. So there are many studies looking at the pre-myopic school-age children and what is actually meaningful in everything that I have mentioned, including vision, spherical equivalent, axial length, CR ratio, and subfoveal choroidal thickness. What is the most important ones? Well, the most important ones with great evidence is the spherical equivalent, parental history, and age of the patient. So these are the ones we have to make sure that we put an eye on. Let's say we have a patient with a low spherical equivalent, two parents with myopia, and a younger individual. So he's not a 12-year-old, he's 6 or 4-year-old, then that will make me more concerned. So there are population-based studies looking at everything that have been described, and they also have found with great evidence that having an axial length of more than 21.4 millimeters and an ALCR ratio more than 2.77 puts you at a greater risk and associated with an incident of myopia. So in the modern day of digital gadgets and everything digital, and we have an app for everything, do we have an app to predict myopia and pre-myopes and who's at risk? Well, the answer is yes. These two, BHVI calculator and the PRIMO, is something very useful. This is the Global Myopia Center PRIMO, where you can put in all of the information and it can predict myopia progression in that patient. So you can put the age, the ethnicity, the time he spends outdoor, and it will chart where that patient stands in the risk. So you counsel your parents and tell them. If you have a patient who's pre-myope, you will look at his risk of developing myopia and you will chart him in the pre-myopia risk. So if you have a 6-year-old who is 2.5, then the risk is low. Well, you change it to 0 right there. You give him a parent with myopia, low outdoor time, and then you can actually show the parents how highly likelihood he might develop myopia. And that's very useful in informing them and counseling them with all of the pre-myopia management. So you have something that you can actually relate to while you counsel parents. So hyperopic reserve monitoring enables personalization and evidence-based prevention of myopia progression and risk in children, and refined threshold based on ethnicity is very important. And this will guide our treatment in pre-myopes and maybe integration with AI for risk stratification in the near future. These are my references, and thank you very much for listening.
Thank you, Dr. Satya, for this insightful presentation and for highlighting the environmental factors influencing myopia development. Our next speaker is Dr. Liana Al-Labedi, Assistant Professor at the Faculty of Modern Sciences and Doctor of Optometry from the Arab American University of Palestine. She'll present Advancing Myopia Management with Contact Lens Solution. Dr. Liana, over to you.
You can see my screen?
Yes.
Okay, great. Okay, so I will be discussing orthokeratology and multifocal soft contact lenses. I'll be talking about certain designs of contact lenses today and some brands of contact lenses, but I have no financial disclosures. So this is a very heavy topic, and I'm gonna try and make it as simple as possible in the 20 minutes that I have. And my ultimate goal by the end of this lecture is to hopefully motivate those of you who are not doing any myopia control in their clinical practice to at least start learning more about it. So we will be discussing a little bit about the risk assessment, which Dr. Shada already discussed. We'll talk about the various designs and the mechanisms behind ortho-K and multifocal contact lenses. And then we'll do some fitting pearls at the end of the lecture. Okay, so as far as the risk assessment, so by now, I mean, all optometrists are seeing myopic patients, and in the past couple of years, at least, we started changing our the way we manage these patients. Maybe 10 years ago, 15 years ago, when I was a student, we would be just prescribing a normal myopic lenses for these patients. But now we really need, every myopic patient that comes into our clinic, we need to check for the risk factors that Dr. Shada has already mentioned. And specifically, I want to address 3 major risk factors: the age. The age plays a big factor. The younger the patient, the more myopic progression we'll see with this patient. I want to address as well binocular vision disorders, specifically low amplitude of accommodation, high ACA ratios, because not all of optometrists, specifically in the Middle East, are doing binocular vision testing as part of their comprehensive eye examination. And I also want to highlight the age normal refractive cutoffs. This is really important. Cycloplegic spherical equivalent refractive error is the best predictor for myopic onset. Again, if we have a patient, a 6-year-old patient that comes in with less than 0.75 diopter hyperopia, we need to at least flag this patient as a possible myopic patient in the future. We need to start the discussion in our office when the patients are presenting to us, even if they are not diagnosed with myopia. So as far as the workup testing, no matter for any myopic patient or any pre-myopic patient that comes in, we really have to do a full comprehensive eye examination. Again, a full binocular vision workup, best corrected visual acuity, cycloplegic refraction, complete ocular health assessment, And obviously, axial length assessment is essential, as it's it's going to guide our treatment intensity, specifically when we're talking about orthokeratology. So when we're discussing contact lenses, whether it's orthokeratology or multifocal soft contact lenses, it's important to do a keratoconus screening on these patients. So doing a corneal topography, whether it's tomography or topography, is essential, because we know that we are seeing increase in the prevalence of pediatric keratoconus. And we know that keratoconus patients also have myopic progression. So we really need to highlight whether this myopic progression is related to just myopia or the fact that the patient may have early signs of keratoconus. As far as the workup for any patient that we are considering for orthokeratology, aside from topography, we want to be doing a full dry eye assessment. We need to also do pupillary size assessment, as well as the horizontal visible iris diameter, which we will need in order to select the proper lens. For multifocal soft contact lenses, additional tests that we need to do include ocular dominance testing, over refraction, as well as a complete dry eye assessment for both orthokeratology and multifocal soft contact lenses. Okay, so how myopia control works, we already know that previously, historically, we only focus about the central rays. We know that a myopic patient will have the central rays focused in front of the retina, but we never paid attention to what happens in the peripheral retina. So for the peripheral retina, even if the patient is corrected with myopic lenses, okay, these peripheral rays are focused behind the retina. And what happens with these peripheral rays, we can call these negative aberrations. These negative aberrations send a signal to the choroid to decrease the blood flow. And this, in turn, will cause choroidal thinning and scleral weakness, and will trigger myopia progression, will trigger axial length growth, and eventually drives myopia progression. And that's the whole idea behind, of course, this is called hyperopic defocus. And so with the myopia control modalities, no matter what they are, the idea is to ensure that these peripheral rays are focused in front of the retina, driving what we call a myopic peripheral defocus. So both orthokeratology and soft contact lenses drive myopic peripheral defocus. Obviously, as far as orthokeratology goes, we think that the exact mechanism underlying the myopic control effect is not really fully understood, and that there are other things going on aside from promoting myopic defocus, including the fact that patients wearing orthokeratology lenses will have higher aberrations, they will have improved accommodative accuracy, and they will have also increased in choroidal thickening. And all of these will ultimately improve or result in elimination of the axial length growth. For multi-soft contact lenses, the same idea. So whether we are wearing a medium add power contact lens or whether we are wearing a high add power contact lens, both of these additions will result in inhibition of axial elongation. Okay, so who is a candidate to wear orthokeratology? Who is a candidate to wear multi-soft contact lens? Assuming that we have a patient in our chair, and this patient is interested in contact lenses, and we already know he's myopic and he's at risk to develop more myopia in the future, and we need to make the decision. What do we do, orthokeratology or soft contact lenses? Both will work very well. The literature says that they are both effective. The right choice really depends on the lifestyle of the patient. So orthokeratology is recommended for a child who is active, who's involved in contact sports or swimming, who wants a completely free correction during the daytime. We want a patient who's motivated, whose parents are willing to also be involved in the contact lens wear and care process. As far as multifocal soft contact lenses, these would be ideal for patients who are anxious about overnight wear. As we are aware, orthokeratology patients will wear the contact lenses during sleep and then take them off during the day. So some parents may be really apprehensive or anxious about having their children sleep with contact lenses, so they may prefer multifocal soft contact lenses. And also patients who've never worn contact lenses previously, they may prefer to wear soft contact lenses versus hard contact lenses. So how effective are orthokeratology? How effective are multifocal soft contact lenses? We have more RCT studies conducted on multifocal soft contact lenses, but we have evidence on both. Obviously, the RCT studies on multifocal soft lenses is a little bit stronger, but we know that both are effective. And in multifocal soft contact lenses, axial elongation is reduced between 30 to 55%, while in orthokeratology, the axial elongation is reduced between 40 to 60%. Okay. So I want to discuss one of the most important pieces of evidence that we have on multifocal soft contact lenses. This is the BLINK study. And the BLINK study was a study conducted over a period of 3 years on children between 7 to 11 years of age. And what they found, the major result of this study, is that higher ads in soft multifocal contact lenses produced much better myopia control in terms of less axial elongation. Okay, so now we know that if we have an option to prescribe between a plus 150 ad and a plus 250 ad, then maybe specifically in patients who we suspect will progress at a faster rate, maybe we need to select the plus 250 ad. Okay, I will discuss a little bit about the orthokeratology lens design. Again, for orthokeratology, we know that orthokeratology has a reverse geometric lens design. And what that means is that with the regular RGP lenses, the cornea is steeper in the center and flattens toward the periphery. But with the reverse geometry lenses, it's the opposite. The lens is flatter in the center and then steepens toward the periphery. So what we know about these orthokeratology lenses is that the central back optic zone is flat or flatter than the cornea. And the zone surrounding it, immediately surrounding it, this is called the reserve curve, is actually steeper. And this creates a pressure gradient that redistributes the corneal epithelium overnight, flattening the center and pushing a ring of tissue outward in the mid-periphery. And this ring of tissue in the mid-periphery is actually what drives the myopic defocus as far as orthokeratology goes. The single most important thing about orthokeratology is not really the fluorescein pattern, not like regular RGP. We really care about centration. The treatment zone alignment over the visual axis is the single most critical factor for optical outcome. There are a variety of designs. We have spherical designs that are usually prescribed for patients who have less than 1.5 diopter astigmatism. And then we have toric designs or customized designs for more higher astigmatism patients and patients who have challenging corneal shapes. As far as how do we select lenses for orthokeratology, Diagnostic fitting still exists today, but I think now the trend in orthokeratology fitting is using topography guided fitting. So we're actually sending, and for that we have to have we have to have good topographers that can give us eccentricity values, horizontal visible iris diameter, and pupil size values. So we send these values along with the refractive error values to the laboratory that we're working with, and they will be able to design the lens that's best suitable for these patients. Okay, as soon as we select the proper lens for the patient, we will dispense this lens in office, of course, and then we'll have the patient go home with it. And what we're looking for as far as the fluorescein pattern, again, fluorescein pattern is not really important, but just we're looking for this bullseye pattern, but not so much on the slit lamp as much as we want to see it on the topography. We want to see central flattening zone, and then we want to see this this steeper ring surrounding this this flat zone. And this is this red steep zone right here is the zone that will be responsible to induce the myopic defocus. Obviously, for these patients, again, the importance of topography cannot be overlooked. Topography is important for patients with orthokeratology because there are certain cases where patients may have issues with this central touch. For example, we see here, this is called a smiley face pattern, where we see that the flat zone is pushed downward. And here, this is a frowny face pattern where we see that the flat zone is pushed upward. This tells me that the lens is not well centered on the eye, and in turn, we will have some issue with the treatment zone and with controlling myopic progression for these patients. So after we dispense the lenses, we want to follow up with this patient the morning after. We want to follow up with them a week after, a month after, and then every 3 to 6 months. So very thorough evaluations for these patients. For soft contact lens designs, it's actually very simple. We have 3 designs available. These are the aspheric gradient multifocal designs, which most of us have seen before when we fit our presbyopic patients. The Biofinity multifocal, ProClear multifocal, these are monthly lenses. Then we have the dual focus myopia control lens. This is the only FDA approved lens for myopia control. It's a daily disposable contact lens. And then we have the extended depth of focus lens. Obviously, they all work in the same mechanism. The end result is myopic defocus that will ultimately reduce or eliminate the axial elongation. They all have excellent efficacy according to literature. The only difference is there are certain optical differences that I will not discuss in details. But we need to know that the MySight 1 day is a daily disposable, as well as the natural view enhanced multifocal 1 day. But I know it's probably not available in all countries, but I think MySight is available in most countries, specifically in the Middle East. So for multifocal soft contact lenses, the fitting is much more straightforward. We have to do a cycloplegic refraction. We select the manifest refraction based on the vertex corrected spherical equivalent. Again, for these lenses, we don't have any studies. If the patient has high astigmatism, higher than 1 or higher than 0.75, we don't have any studies on multifocal toric contact lenses for myopia control. So this is one of the limitations for that. And each contact lens, each design has their own manufacturing guideline. So as far as the fitting and how we select the lens, we have to refer to the fitting guideline. But The basic fit assessment is similar to any soft contact lens. We have to look for full coverage, good centration, good movement. And obviously, after we put the contact lens in our office, we want the patient to at least wait for 20 to 30 minutes before we do this assessment. And what we are looking for as far as the near ad is we want to push the most plus ad that the patient will accept visually, okay? So when assuming that we select a plus 250 ad for this patient, we want to measure their distance visual acuity, we want to measure their near visual acuity, and ensure that they are actually happy at distance and at near. And if we do need to make modifications to the visual acuity through over refraction, we prefer to make the changes on the sphere rather than the ad initially. So patients who are wearing soft contact lenses, in order to have the best myopia control outcomes, they need to be wearing these contact lenses for full waking hours, at least 8 hours, consistently every day. These patients should be reviewed back in our clinic every 3 to 6 months. Again, if these patients for some reason return back to our clinic with myopia progression, before we go and change the design, we have to go back and look at the compliance. Are the patients wearing their contact lenses on a daily basis? We have to reassess the centration and the movement. We have to confirm the ad power before we go ahead and change the modality to something else like Ortho-K, spectacles, or atropine. I want to address this axial length growth curve. Dr. Shada already mentioned it. This is based on a study done on European population, and it's also been done on a Chinese population. But this is so important, specifically for Ortho-K, because the only way we can monitor the myopia, the success or the effectiveness of myopia progression in Ortho-K lenses is through axial length measurements. And what this curve tells us, if, for example, we have a patient that's, say the patient is 10 years old and their axial length is, let's say, 25, we know that this patient has a really high percentile, about 87 percentile, for their myopia to, or for their axial length to increase in the future. This is so important for early cases of myopia. So if we have a patient that's above the 50 percentile as far as their axial length, we really need to flag this patient as a high-risk patient. And we need to start discussing myopia control options with these patients. So this is a really nice graph that we should be using ultimately in our day-to-day clinical practice. Parents are always concerned, how can children wear contact lenses? Is it safe? All the studies so far say that orthokeratology are absolutely safe, even if we have to sleep in them. The major risk factors or the major side effects that have been reported in orthokeratology are really associated with poor compliance, poor hygiene, rather than the lens design itself, or the fact that the patients are sleeping in the contact lenses. The same thing goes for soft multifocal contact lenses. The studies say that they're absolutely safe, that children actually, the rate of complication in children is similar to that of adults, and that we really need to do a very good job in communicating with our patients and their parents, patient education on compliance, hygiene. We need to ensure that the children are actually mature enough to handle the contact lenses as well. Okay, so if we have a progressive myope, if this patient is interested in contact lens wear, and if they are interested in having daytime freedom with absolutely no glasses or contact lenses, then we need to consider these patients for orthokeratology. Specifically, if the parents do not have any concerns over overnight sleep. If they are interested in contact lenses but have any issues over overnight lens wear, then we should probably consider these patients for multifocal soft contact lenses, assuming, of course, that these patients do not have any early keratoconus signs, assuming that they don't have any dry eye. Dry eye and keratoconus, they're contraindicated specifically in orthokeratology contact lenses. So this is something that we need to take into consideration. So early intervention matters. As long as you are discussing myopia control options with your patients at an early age, the better outcomes we will have. Axial length is a very important vital sign for myopia management. So if you are working with myopia control, a scan is an important tool that you need to have in your practice. If you are considering contact lenses, both orthokeratology and multifocal soft contact lenses are excellent options. But orthokeratology would require you to have a laboratory consultation. I know, for example, in Palestine, we don't have that option, and the accessibility to a laboratory and consultants is not always feasible. So for us, orthokeratology may not be feasible, and we may be trending toward going with multifocal soft contact lenses. Patient selection is really important, and obviously ongoing monitoring and treatment are essential. And these are my references. Thank you.
Thank you, Dr. Liana, for this excellent presentation and for sharing your expertise on contact lens strategies in myopia management. It is now my pleasure to invite Dr. Peter Essig, Medical Science Liaison and Project Manager at ZEISS Vision Care, Middle East and Africa. He will discuss new challenges in myopia management, how M.O.V.E technology is redefining optical intervention. Over to you, Dr. Peter.
Thank you very much. Just for confirmation, can you hear me and see my screen, please? I hope so. So, welcome everybody. Thank you very much for taking part of this nice webinar. Also, thank you very much for the two speakers before me, Dr. Liana and Dr. Shatta. Really, really nice talks and really setting the level of the webinar pretty high. So I will just try my best to keep up with you. So in my today's keynote, what I would like to share you with is basically new challenges in myopia management and how M.O.V.E technology, which is like the new technology of the new lens, is actually redefining the optical intervention. So the agenda of today, we will go through some short introduction. Pretty much everything is already well known or mentioned, so we will just briefly fly through. Then mentioning the CARE technology, because we are now understanding it as a fundamental pillar for further innovation. Then we will focus on the new M.O.V.E technology as a continuous strive for innovation. And I'm really happy that I will be also able to share with you the first clinical outcomes which were recently published at ARVO. So who could not participate at ARVO annual conference, the clinical outcomes will be shared here. So in terms of introduction, we all pretty much know the famous statement of Brian Holden back from 2016 that about 50% of mankind by 2050 will be myopic, yeah, maybe even sooner. So this gives us really a huge chunk of people really being associated or being affected by myopia. And actually, not to make this scenario even worse potentially, we need to act now because, I mean, 2050 is unfortunately not that far away from us considering we have already 2026. Yeah, so we are actually closer to 2050 rather than 2000. Yeah, so having this in mind, we really need to act now. This whole prediction that 50% of global population is actually, as said, is meant for the global population. If we focus now on our local numbers from the Arabic and African countries, we can actually see a similar trend, which is pretty much like frightening, right? So, for example, here a study conducted in Taif in Saudi Arabia, having a really big cohort of children, nearly 4,000, as you can see. And what they found out that the myopia prevalence here, or the children really being affected with myopia in 6 to 9 years old and 16 to 18, it nearly doubled. Yeah, so really just during this short period of time, and it was also mentioned here before, we cannot associate everything just with genetics, but more like the behavioral factors which dramatically changed over the years. So even this within this short period of time, which like gives us not even 9 years, that the children attend the primary school, the myopia really increases dramatically. And even if we take a look on African countries, we have, for example, here a nice study really stating that Africa has approximately doubled since 2010 in terms of myopia prevalence, and it's projected to rise threefold by 2050. Yeah, so this gives us really like insights that all these prediction models that were run under some global parameters are really applicable even to our local countries. So the statement I really like a lot is that the region we are at is not at low risk. It's just or might appear to be at an early stage. Yeah. So uh, most probably over the time in your clinical practice, there will simply be more and more children slash parents with their children coming to search for help in terms of myopia management, myopia control. Yeah. The problem with myopia is, of course, and it's also pretty well known, this is just a short recap, is the really close relation to some secondary eye diseases, right? So we are not talking here about just a basic refractive error, which could be corrected with a random minus lens and basically send the patient goodbye, but rather the juvenile myopia, which of course is a function of the eye elongation, is then really closely associated with some secondary eye problems, right? Like the maculopathies, glaucomas, cataracts, and so on. So suddenly we are not talking really about a basic refractive error, but rather some vision-threatening ocular disease. Yeah, and of course, in the clinical practice, it's much easier to solve the myopia or to control or manage myopia rather than solving these sort of secondary eye diseases, which in vast majority of cases are unfortunately irreversible. So here, first of all, what I would like to like refresh maybe, because I believe that the vast majority of the audience here is pretty well aware about this technology already, and I also believe that the vast majority already had a hands-on and prescribed and really saw how the lens really works under the real life conditions. So just to refresh it and really take it as a fundamental pillar for the further innovation we will be talking about later on. So this is the Care lens. Yeah. So the Care lens was the first high performance myopia management lens available here in the local market in Middle East Africa. It was defined originally by two key technologies. One was the first was the Care technology projected on the front surface where you had those defocus elements. Actually, Care stands for cylindrical annular refractive elements. So these elements held a certain defocus level in order to modify the position of the peripheral image in front of the retina. On the other hand, the clear focus at the same time minimized the hyperopic defocus, yeah, especially from the clear zones in between of the defocus elements, where basically the lens held the same optical power as the center. So especially those lens region might then project the focus again behind the retina, which for whatever sake we try to avoid. So that's why this second technology was actually projected on the back surface of the lens in order to modify to eliminate the hyperopic defocus. And here came the really nice the nice translation of the really deep science into an optical design of a myopia control spectacle lens, right? So already back in the days, it was found out that our retina is of course not uniform, right? You have different distribution of the rods and cones and different distribution of the SML cones, right? And everything differs, in the horizontal and vertical meridians, and if you are within the foveal region or outside the foveal region and whatever. So there are a lot of things actually happening on the retinal level itself. And this is actually pretty important in myopia control because actually the retina is the tissue which is accepting the defocus signal. So we've been already investigating this back in the days. and finding that the mid-peripheral retina, which is about 6 to 10 degrees, I mean, of course, with some variance because this is simply some biological data, but by thumb, still 6 to 10 degrees is considered as a sweet spot for this positive defocus detection. And most probably it's because of the highest prevalence of the S cones, yeah, which are the cones responding to the short wavelengths and that are assumed to be the one that are the most sensitive one for the defocus acceptance or the defocus information acceptance. So then this particular argument was again translated to the optical design of the lens and in a way that the central aperture of the standard Myocare lens was really designed upon this argument or upon this argument among the others. Yeah. So this is really like the cool thing how the deep science can be then translated to the optical design of a Myopia's control spectacle lens. And actually this happened again as you will see in the future slides, what we have done with the M.O.V.E technology. To finish this so the care lens is then defined by 7 millimeters of the center clear zone and 4.6 diopters of the defocus of the respective care elements. Now before we were just afraid that what happens if the children might not adapt, what should the eye care professionals do then? That's why the Myocare S design was developed at the same time, which was defined by a slightly bigger aperture of 9 millimeters and 3.8 diopters of the defocus of the respective care elements. Now, the strategy is to, of course, first start with a standard care because we can see simply slightly better myopia management with this standard lens, just in case of a non-adaptation that the children really might complain about halo, glares, dizziness, which really happens in a negligible amount of cases, but still you want to have a solution for everybody, and even the 1% of children matters. So that's why the Care S lens really helps. And of course, everything is then covered with the respective warranty. So the parents should not be afraid about any additional costs. What is really cool, what I have found from our team in Germany, that we have now 33 publications of the care technology. So either conducted by ourselves from our interest, or another scientific lab simply used the care lens for further investigations. Yeah, so here are actually the 14. These are the 15 to 33. So we have really now 33 publications. So if you are into science and you would like to investigate more, we can definitely get also in touch and discuss further. What I would like to share with you now is because we are having some updates on the clinical data. So this will come now. So this is just an overview, what sort of institution we are working with, and most importantly, that we are always with the big cohorts. Yeah, so we are not playing around with 10, 20, 30 children, which in terms of statistics, it might be enough, but in terms of really the robust clinical relevance, definitely not. So that's why here always the big cohort is a thing that needed to be mentioned. Not to waste too much time on the baseline characteristics, you just need to trust me that everything was not significant at all with the two respective groups. We will just jump directly to the outcomes. So here, in terms of the 2 years data for the European cohort, we are seeing the psychoplegic spherical equivalent on the left-hand side and the axial length on the right-hand side. I'm super happy that already before it was mentioned that actually the axial length is the parameter that should be tracked. Yeah. First of all, because we with these sort of optical interventions, we cannot modify any sort of lenticular or corneal changes. And at the second time, axial length is the crucial parameter that is then correlated with those secondary eye problems we want to avoid. Yeah, that's why myopia control. So that's why the AL is, of course, always the parameter to investigate more in detail, but still just to have an overview, spherical equivalent is here just in a supportive metric. So we can definitely see pretty significant differences in the 24 months period or 2 years period between the care and single vision. Now, as I said, the axial length is the more important one. So what we actually also found out is that having, all these percentages of efficacy, and just talking about the differences is highly, highly misleading, right? Because then, mathematically speaking, you are highly dependent on your single vision group, right? And if the single vision, I don't know, shoot ups to nonsense, right? You artificially basically amplify your clinical efficacy. So what you actually want to achieve is always more like an emmetropic growth of the eye, or maximum to be on the emmetropic limit. Yeah. So how we do this is that we focus also on the absolute of values of the ocular elongation over time. Yeah. So here, for example, for the 12 months period, it was 0.08. And then we stood pretty much in constant. 24 months gave us about 0.21 millimeters. Yeah, so on average, we are talking about 0.1 millimeters a year for those respective children group. For Asian children, we completed finally 3 years. So we have 33 months period of data. So here what happened, we also investigated the Myocare S. That's why you see three curves. So the black still stands for single vision. Then the light blue is the Myocare S, which is like the softer version. And the darker blue or slash violet stands for the Care technology, the original one. Yeah. So this is also giving you an insight, why the Care should be the first one to pick, because simply the clinical efficacy seemed to be a bit more robust. Still seeing pretty significant differences even after 6 months of investigation. Now, why is this curve of single vision dashed here? This is basically what's also happening in other studies, is basically that at some point you find out that the single vision treatment is simply not meaningful at all to continue with. So then basically you go with a mathematical model and you need to extrapolate the function over a certain period of time. Here it's 1 year, based on your assumption how the children might behave. Now, we did it here just for 1 year, just to complete the study. We know that the extrapolation models might have some limitations, so on that purpose, the study will be now discontinued. We simply stick with the 33 months data, and this is basically how we now proceed. Again, the key information here, because 3 years is already a pretty long period of time. So what again we can read from this chart is actually the absolutes, right? So again, we focus on the 3 finished years, which gives us the 12, 24, and 33 months period of time. And we check the respective absolutes, which on average gives us about 0.2 millimeters a year. Now, what do you do with all those absolutes now? You basically compare it with an independent emmetropic limit, and this is basically the cleanest way how to see whether the lens or whether the optical interventions really supports the normal healthy emmetropic growth. Yeah, so here what you can see on the y-axis, we have the axial elongation in millimeters a year, and we see 2 bar plot families, one for the Asian cohort, one for the Caucasian cohort. In the first bar, we always see the performance of the single vision lens. In the second bar, how the Care technology performed, and most importantly, how close it really was to the emmetropic optimum, let's call it, or to the emmetropic limit, which, as I said, was found from an independent literature just based on the age and the ethnicity of the respective children they were enrolled in the respective studies. Now, this was also mentioned here before, myopia management in pre-myopic cases, and I found it a really, really cool idea. Yeah, so we also tried to investigate here in Chinese children, and again, we had pretty many of them, nearly 150, and we collected emmetropic / low hyperopic children. Yeah, so from plano till 1.5. And they were either dispensed a plano care with no optical power or no treatment at all, just advising them, please spend more time outdoors, take care of your behavioral factors and so on, while having no differences in terms of the age, gender, psychoplegic refraction, and axial length in the 2 respective cohorts. And now we were just interested in, what will be the myopia incidence, meaning the new cases over the following up 12 months. Yeah, while in the 6 months we couldn't see any if treated with the care technology, while about 50% reduction or 10 versus 20 care technology versus nothing at all. Yeah, so this also gives us a hope and some nice scientific insights. What is actually all these defocus, acceptance, and elongation about, and it's actually really cool to see that even though you like try to manage myopia just based on your expectation that the kid might be myopic in the future time, it's actually a meaningful step in the clinical practice. Now, of course, time and adaptation, ease of adaptation needs to be equally investigated. There is this lovely question, which myopia control solution is the best one? And I always say it's the best is the one the children will use. If the children will not use it, basically the myopia management will fail whatever you do. Yeah. So here, of course, the time of adaptation, ease of adaptation needed to be equally investigated. We couldn't see any particular difference in the first wearers for the Care S, Care, or single vision technologies. Now, also the visual acuity over the long period of time didn't really change at all. Yeah, so here we were interested about the change in the BCVA, so best corrected visual acuity in logMAR between the single vision treatment, Care and Care S. Of course, you remember that in the 30 months period from the Chinese cohort, the Care lens got switched to the single vision. That's why here it's stated switch to Care at 30 months. And we really couldn't see any particular difference. Yeah, you need to see how high resolution the y-axis actually has. So there is basically no clinical significance at all. Now, coming to the M.O.V.E technology. So this was basically for us the fundamental pillar, what we have done till nowadays. Now we will move onwards because the Care technology has been with us with quite a long time. So now to really see what can we do more. And there are two key questions. And of course, how to level up the efficacy, because of course, with any other next generation, you simply want to be better than the previous one. And another interesting question is how to maintain the clinical efficacy over time, because we know that from the clinical perspective, all the optical intervention might have the highest efficacy in the first/2 years of wearing, and then starting to reducing over time. Yeah. So then if you'll be having a patient who really needs to wear the myopia control solution for a long period of time, you need to be sure that actually the optical intervention can deliver the sustained performance over the long period of time wearing. So this is what I would like to shed some light on, and this will be really the high efficacy and the sustained efficacy, and try to see how to solve it. So coming to the foundation of the new optical design, and what we have learned over the recent time is that really the intensity, type, and timing of the stimuli needs to be varied. Yeah. In order to prevent the saturation of the image. I mean, what this sentence means, I mean, it maybe sounds a bit complicated. I have some nice animations, I would say, to really make you understand this sentence a bit more. Just for now, to make it a bit more tangible, in which direction I would like to talk about, it's like if you hit a gym, and I'm assuming you would not lift more weight and you would not change the exercise. Basically, you will just continuously repeat the same thing. Your muscles will simply adapt, right? So at the first point, you might feel some sore and pain, but if you will continue to do so, basically you will adapt to it. And the same goes in the neural side of the thing. So imagine that you will have a whiteboard where over and over again there will be a certain command being printed. For example, here we have print hello world, right? So what you will then see in terms of the neural responding from the retinal pathways is declining or diminishing firing of the neural responses. Yeah. And this actually plays a crucial role in myopia control, because what we need to do is to keep the retina active. Yeah. So here I would like to talk about the dynamic stimulation. Yeah. So here again, just in this example, you need to change the one simple command, which was the print hello world as an example, to different modifications here. Yeah. Because the different modifications will simply keep the retina active and will prevent the higher neural pathways from the adaptation. Yeah, so that's why we need to go in the direction of the dynamic stimulation. So this was the first pillar. The second one was the investigation of the eye movements. Yeah, so what we have found out that the children are really, really big eye movers. So there are a lot of eye movements happening behind the lens, regardless they are wearing myopia control or myopia management lenses, right? So we know that those myopia management lenses, they have a certain aperture, so you might expect that the children would rather move the head to really stay aligned with the gaze axis with the clear zone, which is not true, right? Because as you can see, still it's a pretty much function of the activities the children are at, whether it's walking outdoors, looking at the book, playing a soccer, copying from a blackboard, whatever. But still the standard deviation of the eye movements happening behind the lens is pretty huge. Yeah. So what we need to do here is to really translate it again to the optical design of the lens and develop something that provides an active and spatially variant signal to the retina across the gaze. And the third thing, or the third pillar to complete this, is our learnings from the period of time having the CARE technology. So for now, we are pretty much certain that the visual signals coming from the foveal region are not really relevant in terms of refractive development. Rather, all these signals that are meaningful for the proper refractive development are really coming from the peripheral zone. Yeah, while again, you already remember, the size of the center clear zone really influences the efficacy and the variability. Yeah, that's why the 7 millimeters was set for MyoCare, for the CARE technology, and will also be set now for the M.O.V.E technology, as you will see. And the third part is then it's actually meaningful to shift the peripheral image in front of the retina, because we know that those healthy signals, let's call it, for the proper refractive development are then directed towards the anterior part of the myopic blur. Now, to make a bit more tangible and understandable what I meant with all those gaze-specific defocus and variation and not making the image saturated and so on, there will be three animations. We will start with the most easiest one, and we will always track the gaze-specific defocus over time while having some eye movements happening behind the lens. Here we will have just a normal single vision lens, basically you or me are wearing on a daily basis. So what you would expect in the gaze-specific defocus is, of course, no variation at all. The lens should hold optimally just one optical power, so besides of some off-axis distortions of the lens, there should be no variation at all. With the CARE technology, this is a different story, of course, because this is a myopia management lens. So you have a structure with a certain defocus levels. So if you will be having eye movements happening behind the lens, you will end up in such a binary function. And this is actually the key problem, because this function is repetitive and it gives the eye continuously a uniform pattern. Yeah. And unfortunately, the whole the retinal structures and the higher neural pathways are actually able to adapt to these particular functions. So the solution for this is, of course, in easy words, to create even bigger mess on the retina. Yeah, to really fight this neural adaptation of the higher pathways by highly spatially variant and dynamic signal to really keep the retina active. Now, how we did it is that we moved from continuous elements to distinct elements on the front surface of the lens. This technology is called M.O.V.E, and it stands for Micro Optical Variable Elements. Yeah, so the aim here is to really provide randomly arranged elements of varying power. Yeah, just on purpose to keep the retina active from the highly spatially variant signals. Now, if you take a closer look now, every meridian of the lens is simply unique. Yeah, so the placement of the element is not aligned. So you have no one meridian that would be defined just by the gaps or just by the elements, but there is always a spatial shift in terms of positioning of the elements. Yeah. On top of that, the optical power of the respective elements is randomized as well. So if I jump back here, That's why the spikes are of different heights in random timings. Yeah. So this really shows you that regardless there are eye movements then happening behind the lens, the retina always keep on being active because of the random placement and the random optical powers of the M.O.V.E technology. Now, what stayed in common then with the CARE technology is the size of the central clear zone, which is 7 millimeters based on the arguments I presented before, as well as the clear focus technology, which was then the treatment of the back surface that you also minimize the hypertrophic defocus. Now, the clinical outcomes, I'm running out of time, I'll be really fast, is really just showing how the lens performs. So in the 6 month period, we see about 0.4 diopters of spherical equivalent, but most importantly is the axial length. Yeah. So here in the 6 months period, we can see even axial length reversal. Yeah. So really big amount of children even showed the eye getting shortened or over time, especially beyond what the choroid can do. So we were actually interested in here what was the amount of children having this choroidal thickening. We found out that it was 46 and 43% respectively. And then the amount of the shortening was actually beyond what the choroid can do. So we still need to scientifically understand it, what is actually going on, but it's actually really cool to see such robust outcomes. Now, again, the adaptation came up with a pretty significant outcomes with about 98%. So I'm coming shortly to the conclusion. So what I just wanted to shed the light today was the two key technologies. You have the CARE, which stands for the cylindrical annual refractive elements, which is a technology that provides the readily accessible myopia management. And the most now current one is the M.O.V.E technology that really targets the superior and sustained myopia control over a long period of time wearing. Now, by then, I would also like to invite you here to the ZEISS symposium we will be having at ESO conference by the mid of October, so in like 3 months, where we'll be covering from dry eye solution through all the technologies and myopia management collective, biometry, and so on. So I just had a few slides here on the biometry, just to give you a bit of a teaser, you know, what you can be looking forward to. This would be then the new Myo 200 device, giving the keratometry and axial length measurement, really dedicated for myopia control, associated then with software background, which also, as was presented here before, will guide you through all the risk analysis, interpretation, effectiveness, consumer reports, and so on. So definitely more things to look forward to, and I thank you very much for your attention.
Thank you very much, Dr. Peter, for that informative and thought-provoking presentation. Our next speaker is Dr. Al-Mutej, consultant ophthalmic surgeon and professor of ophthalmology at the University of Jordan. He'll speak on low-dose atropine and combination approaches in clinical practice. Over to you, Dr. Al-Mutej.
Can you hear me now?
Yes, we can.
Oh, sorry for that. Well, going back, thank you very much for hosting me and for being with this very nice group of experts, actually. My talk will be divided into two parts. The first one is talking about the low-dose atropine, and the second will be about the combination approaches. Some of the data that I might present have already been presented and really discussed by the excellent 3 previous speakers. So when we talk about myopia, previously we used to talk about it as a disease. Now we really are talking about it as an epidemic. Nowadays, 30% of the world is myopic. By 2050, it will be half of the world is myopic, which means 1 in each 2 people will be myopic. And what's more important is that 1 out of 10 of those will have high myopia. What does that mean for us as physicians is extremely important. For patients or for their parents, high myopia means just stronger glasses. Makes their eyes smaller. But what does it mean really for us? Well, if you are 1 diopter myopic more, that means you have 57% chance to get more myopic macular. That means 20% chance to have glaucoma more. Also 20% chance to have posterior subcapsular cataract and 30% chance of retinal detachment, only for one dioptric increase. And let's remember that our myopic child today is our cataract patient tomorrow. So we are trying to preserve these patients as much of complications as we can throughout their life. So maybe for patients, it's a number of how many diopters they wear, but really for us as clinicians, it means how much is the axial length of this patient. This is a summary of a lot of studies which were done worldwide, showing the change in the axial length and with age. The left side, the right-sided diagram is for males and the left is for females. And you can see that the highest numbers actually, or the highest burden goes into Southeast Asia. As Dr. Essig said, maybe in the Middle East, we are not far behind what's going on in the world. Maybe we are in just an earlier stage of this disease. Maybe we reach these numbers, especially with the long time that our kids spend over the screens. Maybe we reach these numbers soon. Okay, how does atropine work? Just let you know, atropine was not recently introduced into myopia control. Actually, the first reports came in the early 19th century. How does it work? We really do not know exactly how does it work. Is it the muscarinic receptor blockage? So it's affecting the retina, or it has a direct scleral effect, or maybe there are areas that are still under investigation. Any alternative pathways, any anti-inflammatory or biochemical effects, or are there any direct biochemical effects on scleral fibroblasts? But we really know that atropine does slow axial elongation, which is the theme in myopia control and reducing myopia progression. Okay, well, as we clinicians try to know how to put atropine into our practice, initially we started with the 1% atropine, which is available in the market. It's highly effective at slowing progression, but it's associated with significant side effects. Photophobia, loss of accommodation, poor performance at school. The half-life for atropine is 3 weeks in comparison to 63 hours or 36 hours for the cyclopentolate, for example. And there is a very high rebound risk also. Then we started to study how about optimizing this percentage. Clinical trials shifted focus toward identifying the minimum effective dose to balance efficacy between the comfort of the patient and the safety. And now what we are talking about is what really is the optimal percentage that we can use for atropine. Let's go through that quickly. The first study was the atropine for treatment of myopia study, the ATOM-1 study. That was 2006. It was a randomized controlled trial in Singapore involving around 400 children. They investigated the 1% atropine. And what we were expecting to have is that 75% there was a reduction in myopia progression compared to placebo. This is a huge number. This is a very, very important contribution to the myopia control. Also, the axial length did not elongate in those patients who were receiving the 1% atropine in comparison to the placebo. But that was at the cost of severe photophobia, loss of accommodation, and rebound effects. Okay, so this is the change in the diopter power over time between the placebo and this is the highest graph is the atropine 1% treated eyes. Again, the same effect was observed in the decrease in the progression of the axial length. We know that these patients, the myopic patients, their myopic numbers will increase and their axial lengths will increase. There's a difference between a normal and an abnormal number. We have magic numbers for those. Okay, then came the second study, which is the ATOM-2 study, where we are trying to optimize the percentage. So it was a randomized trial comparing 3 concentrations, the 0.5, the 0.1, and the 0.01. And as you see, the concentration that we are really now using, which is the 0.05, was not part of this study. This came in 3 phases. The first year was phase 1. And then there was 1 year of washout, followed by 2 years of follow-up. And the key findings were the dose-dependent efficacy And we found that higher concentrations were more effective. So the higher the concentration will be, by default, it's more effective, but it had greater side effects. The rebound effect, what do we mean by a rebound effect? We usually know that any patient with myopia, the myopic shift that we consider as normal is less than 0.5 diopter change over 1 year. That's in diopteric power, or less than 0.1 millimeter of axial length increase. So the 0.01% atropine showed the least rebound after cessation, leading to better cumulative results over 5 years. That was the ATOM2. Again, these are the graphs for those patients, talking about the diopter and the axial length. Okay. And the impact of this study was that the established 0.01% was a practical clinical option with minimal side effects compared to the 1% that we used before. This is a summary of the ATOM1 and ATOM2 studies. And you can see that once this line is where we stop treatment. The concentration with the highest effect and the lowest risk factors was the 0.01% in comparison to the 0.1, and the 0.5%. Then it came the LAMP study, which is the low atropine for myopia progression treatment. That's in between 2019 2020 against a randomized double-blind placebo-controlled trial in Hong Kong. And out of this study, the sweet spot, or let's say the optimal concentration that we think that it will give us the effect that we need with the lowest side effects and the least rebound is the 0.05%. So the 0.05% is currently the best balance of efficacy and tolerability for clinical practice among all the atropine percentages. This is the change that we found in spherical equivalence between the different concentrations of the atropine in comparison to placebo, and the highest effect was with the atropine 0.05%. And when we are talking about the axial length, that was again the same with the 0.05%. Okay, this is a summary of a comparison table comparing the concentrations of the 0.05 atropine and the 0.25 atropine and then 0.01 atropine. Again, the highest efficacy is with the 0.05% atropine. Okay, so what are our clinical guidelines? When do we start using atropine? Do we start it early? Do we start it late? And when should we start that? Providing that this is the optimal concentration. You can argue, you can start with the 0.01%, one with the 0.1%. But this is the optimal concentration that gives you the needed control of myopia progression with the least side effects. Our target population is those children where we detect myopia. Those are the patients between 6 and 12 years old who are myopic, and we have to check for progression. Any patient whose myopia increases more than 0.5 diopter per year, or his axial length is more than 0.1 millimeter per year, or they have an early onset below the age of 8 years, this is a candidate for starting atropine treatment. I cannot emphasize more the importance of axial length. I think Dr. Rayana already spoke about the importance of axial length in the follow-up of patients who are using orthocartography. Okay, how do we monitor them? This is the follow-up protocol, usually every 6 months to assess efficacy and tolerance. It's very important to tell the patients that we are trying to control the myopia progression. We are not aiming for stoppage with the myopia, this myopia. We know that myopia will increase with age. These kids will be adults. Their eyes will grow. Their axial length will be higher. But still, when my child is a myope who will end up with -4 at the age of 18 or 19 and expecting to have LASIK at the age of 20, this option might not be an option for him if his numbers were -8 or -9 at that age. And for how long do we continue treating those patients? Usually we do it for 2 to 3 years or until their progression stabilizes. And interestingly, we have a lot of patients whom their myopia does not stabilize at the age of 18. There are more patients who continue to develop progression of myopia up to the age of 20 or 22. Okay, what side effects do we expect? As we said, the less the concentration of the atropine, the less the side effects that we have. Still, some patients might have photophobia, and we control this by photochromic lenses or sunglasses, some near glare, and this is higher this gets worse with the higher concentrations. This is very rare with the low doses. Sometimes we might need a plus for them to read, and very few patients, they have allergy to the atropine. Okay, how do we prepare it? Well, if you are lucky enough, there are parts of the world where it is already there commercially. If it's not, then simply this is how we do it. You just get 0.5 millimeter of the atropine 1% and put it in a sterile 9.5 millimeters of any preservative-free lubricant. And we use it once daily, every night, for the period of treatment that you would like to. Okay, so about the atropine, the optimal regimen is 0.05%. This is the most effective low-dose regimen, but supported by randomized trials for axial length control. This treatment should be combined with lifestyle advice, especially more than 2 hours per day, and that was really presented with Dr. Shada by the first presentation. We have to monitor the axial length, not only the dioptric power, because this is really the most objective marker of refraction. That's influenced by the psychological levels. And our long-term goal is axial stability to protect long-term ocular health and reduce the risk of future complications. Now, this is for the first part. The second part of my talk is, do we really have to do other measures with atropine, or this will be enough for our patients? Well, actually, it might not be enough for some patients. So, fast progressors, those who, I think that again was explained by Dr. Shada early, there are things that tell you that this patient is a high risk, paternal myopia. The risk that he will have if he has a very strong family history. This starts very early. If we start with very high numbers. Dual pathways, combining pharmacological, specifically atropine, and optical, which is the myopic defocal treatments, targets different physiological mechanisms. So this might be synergistic, actually. And there's an evidence that suggests that synergistic effect of both treatment provides superior axial length control compared to either alone. Okay, the very well-known synergistic effect that we have is the atropine with the ortho-K. And if you have somebody, as was explained by Dr. Layana, if you have somebody who is really expert in performing ortho-K, this will be the magic combination for your patient. And this is actually the most studied combination in myopic control. They do synergistically work. They work in 2 different pathways. Atropine works in its pathway to inhibit the growth of the eye, and the ortho-K works on the peripheral defocus. And there's a clinical evidence that 65 to 70% reduction in the axial length, which is our aim in those patients. Okay, how about other myopia control spectacles? I will not mention any name. I'm just talking about the concept here. This is an non-invasive synergy combining low-dose atropine with advanced spectacle designs. Choose whatever design you want. The IMS, HOLT, DOT, MyoCare, etc. The key benefits in those effects is that there is no contact lens related infection risk. That does not mean that contact lens is a bad option. It's a very good option. That was clearly explained by Dr. Ayana in her excellent presentation. But simply you get night drops with daytime glasses. It has an excellent safety profile for younger patients. The ideal candidates for this is children not suitable for contact lenses or ortho-K, or you do not have this facility, as Dr. Ayana said, or the high-risk progressors requiring additive control. You started them on atropine, but they are still progressing. Or families who prefer non-invasive interventions. Okay, these are some types of the lenses that we use in myopic control correction. All of them share one basic optical principle. The central zone is not affected, and the peripheral zone works on the myopic defocus. I can't stress more on that issue. Okay, comparing major intervention, the strongest combination, as I said, is the ortho-K with the atropine. It has the strongest synergistic effect, dual pathway control, and it's the most studied as well so far. How does this work? Atropine works by its, well, let's put it into brackets, the unknown specific mechanism of action. And the optical pathway mainly works on the peripheral myopic defocus. How about the fast progressors? That means somebody who progresses more than 0.75 diopters per 6 months or more than 0.3 millimeter per year. Well, first of all, optimize your dose. If you are using 0.01, maybe you have to increase it to 0.05. If this is not working, you might need to add optical control, either ortho-K, lens-specific lenses, soft contact lenses, in addition to the lifestyle audit. I have to stress here that the audit of lifestyle studies say that they are very effective in preventing myopia to start. But if myopia starts already, they only have a negative effect, but it's not as good as if you started early, which means that prevention is always better than cure. Consideration in using combination studies, ortho-K risk, as Dr. Liana said, I will not repeat that. Regimen complexity, but you have to address also the cost-benefit analysis, because this is something expensive that families, especially if they have 2 or 3 children with the same pathology, this is something that will be more expensive, but the long-term value of preserving ocular health and preventing high myopia complication justify this investment. Again, our pediatric patient who is myopic now is somebody's cataract patient 20 or 30 years from now. So preventive power, outdoor exposure more than 2 hours per day is very effective in preventing the onset of myopia. Therapeutic adjunct, while the effect is smaller once myopia is established, outdoor time still plays a role as an objective recommendation with medical control. Aim for at least 2 hours of daily outdoor activity, follow the 20/20 rule to decrease that with stress, and prescribe lifestyle changes with every medical intervention. The summary of what I've said is that atropine has a role. Additive effect is very well known, especially with atropine and ortho-K. Axial stability is our aim. Personalized care, you cannot put one regimen for every patient. You have to modify it. And there are a lot of future horizons in this particular field of medicine. And thank you very much.
Thank you, Dr. Almutej, for sharing your valuable clinical experience. We are now pleased to welcome Professor Yazan Gamo, Professor of Optometry and Chair of the Education Committee of the World Council of Optometry, together with Mr. Rashid Jarur, Senior Optometrist at ZEISS Vision Center, Jeddah. Their presentation is entitled as Real World Myopia Management Cases from the Middle East. Professor Yazan and Mr. Rashid, welcome. Over to you.
Thank you, Swarna. Am I audible and visible?
Yes,
And
Dr. Yazan.
Can you see my screen as well?
Yes, we
Lovely.
can. Yeah.
Thank you so much. So good afternoon, good evening, everyone. And thank you so much for allowing me and Rashid to share some of the cases that he worked on at Battle Center in Jeddah. So Rashid and I go way back. He used to be one of my students at the master's program at AAUP University, and I'm currently co-supervising his final master's project. It's always an honor to work with students who are colleagues. So just for acknowledgements, I'm a fellow of IACL, International Association of Contact Lens Educators, and any material that was obtained from IACL has been properly cited. And Swarna, thank you for mentioning that I'm the chair of the World Council of Optometry. That was just right 2 hours ago. 2 hours ago, my chairmanship has ended, and there's now a new chair for the education committee. So I'm no longer affiliated with WCO, just so that everyone would know. So what we're gonna discuss in the next few minutes, the idea is we have a panel of great speakers, but Dr. Shada really have set up the tone perfectly. Liana has done an amazing job. Peter showed nicely all the technology of lenses by ZEISS. Dr. Mu'taz had shown us how Ophthalmology can manage such cases in collaboration with Optometry. And here we're going to see like a cumulative effort of optometrists and ophthalmologists in managing myopia cases. We only selected 3 cases due to time restrictions. We had 6-month and 12-month follow-up. Unfortunately, unlike the 2- and 3-year studies shown by Peter, we have data from spherical equivalence refraction and axial length for most of the cases. And we'll be trying to benchmark evidence from published research. So Peter mentioned ARVO, the Association of Research in Vision and Ophthalmology. That's a huge conference. Every year they do it in the US, where companies and researchers show all their work. And I thought maybe we'll just focus, rather than the Asian studies, we'll focus on the European data for MyoCare, because European cohorts are very similar to Eastern Mediterranean cohorts in terms of axial elongation and distribution of refractive error. So basically, using a single vision lens, the European cohort showed an increase of almost 0.43 diopters of myopia. However, by using MyoCare, that progression was only 0.21, which translates to almost 54% reduction in myopia progression, which is quite impressive, to be honest with you. They also showed almost 51% reduction in axial length. I didn't show the data for axial length, though, for MyoCare, just to make it simpler. MyoActive, that has been discussed by Peter, I called it Shanghai Novel Lens Trial, because that's how it was described in the trial. And in that very interesting study, axial length was reduced by 88% compared to children who were wearing single vision. So we're gonna see an interesting lens, hopefully, in the near future in our market. So, and I'll let Rashid go on with a couple of cases. Then, if he allows me, I will focus on the 3rd case. And the floor is yours, Rashid.
Thank you so much, Professor. Thank you for that very beautiful introduction. So just a quick disclaimer before I start with the cases. This is also worth mentioning, as Professor Yazan said, that all the cases mentioned actually come from the myopia management clinic that is in Jeddah, Saudi Arabia, within ZEISS Vision Center by Dr. Batal Vision. So the first case that I will be discussing, it's a male. He was born in 2011. He initially came in 2018 and presented with this cycloplegic refraction, which is just plano over -1, and then plano over -1 in the other eye as well. He then later on presented in 2025 at 14 years old, presenting with cycloplegic refraction of -7.5 over -2 in the right eye, and -7.25 over -2 in the left eye, reaching 20/20 in both eyes. And this is such a huge shift between just in 5 or 6 years. So this patient was later on given MyoCare, specifically after this visit. And then he presented 6 months later. And as we can see, in 6 months, the cycloplegic refraction in the right eye was -7.25 over -2. The left eye was -7 over -2. And in the 12-month follow-up, it was still stable refraction. But what we found really interesting in this case is that this patient wasn't only stable when we're comparing between the initial visit and then the 6-month follow-up. We actually saw a 0.25 improvement in both eyes. And this is after eliminating all the accommodative component. So we are comparing raw cycloplegic refraction between the initial visit, 6-month follow-up, and 1-year follow-up. So between the 6 month and 12 months, we found to be complete stability. However, we did find a 0.25 improvement in diopter. So there was not only no myopic progression, there was actually myopic improvement. Even though it was subtle, but it still meant a lot that we didn't have any progression or stability. We actually had improvement. And when we look at the graph here, we find a very huge shift between the primary visit and then the 2025 visit. We found almost a spherical equivalent progression of -8 diopters. And then to have not only stability, but also improvement was the key factor in us presenting this case. And then we go to the second case. So this is another male. He was born in 2015. He was initially scheduled for squint surgery. And after the squint surgery had already occurred, because, we cannot proceed with prescribing myopia management spectacles if we don't have aligned vision or healthy binocular vision. So after the squint surgery has been done, we can see the cycloplegic refraction as following. So it's -2.5 or over -2.75 in the right eye, while in the left eye, it's -3.5 over 2.5, with axial length in the right eye being 25.45, the left eye being 25.9. Then this patient was prescribed MyoCare lenses. So in the 6-month follow-up, the cycloplegic refraction is still as is. It's still stable. There was no progression. So when we compare the initial visit and then the 6-month follow-up after using MyoCare lenses, we found the spherical equivalent of cycloplegic refraction to be completely the same. However, we look at the axial length and then we find 25.5 in the right eye, 25.96 in the left eye. So this means in the right eye, we had elongation of 0.05, while in the left eye, elongation of 0.06. So when all this data is being compared to the expected axial elongation of single vision myopic children, and then we also compare the data of the case just presented with the expected axial elongation of children wearing MyoCare lenses, we found them to be very, very close. So the expected MyoCare axial elongation of being 0.047, and then in the case 0.055. So we found that the axial elongation was very minimal, and to put it like as is, it was just as expected of such modality, as well as we found complete spherical equivalent cycloplegic refraction stability.
Thank you, Rashid. May I add something here? We chose to recalculate data presented by ZEISS from their MyoCare trials in Europe. And it just proved to us that emmetropization and myopization in European cohorts could be very similar to Eastern Mediterranean cohorts, at least from our part of the region, the Gulf region at least. And so this is encouraging for those who are interested in conducting research to, start, as they say. So Rashid, may I present the third case, though it's yours, because it's a little bit complicated in terms of data. So we have a female born in 2013. She's almost 13 years old now. In her first visit with cyclorefraction, had 20/20 vision, almost minus 3.5, minus 0.75, left eye minus 3.25, minus 1. And the axial length was as big as expected, 25.37, 25.29. We did a 6-month follow-up using MyoCare. Under cyclo, there was 3.75, 3.25. That's almost just only like a quarter diopter change. Nevertheless, a little bit of axial elongation, which is fine. A bit concerned here with the 12-month follow-up. In terms of refraction, that's okay. It's almost still quarter diopter, which is less than the 0.5 change expected. So even better than published data. Nevertheless, axial elongation was a little bit longer than expected. So basically, although observed spherical equivalent of refraction progression at 12 months is almost as similar as published Myocare data from Europe, and significantly much better than children who were wearing single vision, almost only quarter diopter change, which I'm very happy with. The thing is, the observed mean axial length change, if it's translated into percentage efficacy, it's only 23% compared to the 55% efficacy reported in literature. Does this mean the Myocare lens is not good? Absolutely not. We've already proved that it's a very good lens. However, this supports a monitoring-based individualized management. Not all children are the same. Their eyes might progress differently. Dr. Shada has already highlighted the fact of visual hygiene. Perhaps we need to emphasize for the child to do less recreational near work and do more outdoor activity to reduce the chance of myopization. Perhaps we need to combine Myocare with atropine, so probably Rashid will do that next. However, he might consider changing the lens to Myoactive once it's available in the market, but meanwhile, he will do a combination therapy of Myocare and atropine. So other possible explanations, compliance. Dr. Liana mentioned compliance in terms of contact lenses, but it's actually quite important in relation to spectacle lens use. I've conducted a study for the Institute of Family Health here in Jordan, which is part of King Hussein Foundation. May his soul rest in peace, of course. And this study was supported by the Ministry of Health here, and we found out that 71% of children comply with spectacles. Almost 30% of the children who wear just regular single vision lenses don't comply, and they do not wear them regularly. So that is something we as practitioners need to emphasize with the parents and the children. Age-wise, perhaps adaptation, there might be an individual retinal response. Remember, let's go back to Peter's presentation on the sinusoidal pattern of Myocare and the chance of the neural adaptation. Remember, our brain's plasticity is something individual. And let me get back to that. So with the Myoactive lens, the concept of breaking this sinusoidal modulation might prove to be useful in such a case. So it shows that you need to have literally an arsenal of management options. You need to monitor using the tools that Dr. Shada has mentioned. You need to have a very good biometry and patients who are compliant and follow up. And with that, I would like to thank United Optometrist Forum and ZEISS for allowing me and Rashid to show some of real clinical cases to all of you guys. Thank you.
Hello, hi. Good evening, everyone. Thank you, Dr. Yazan, for that wonderful presentation, and Mr. Rashid for the very excellent clinical cases. And a sincere thank you to all our speakers for the excellent and insightful updates on myopia management. It's been a highly informative session, and I'm sure everyone here has gained the valuable takeaways. We will now move on to our Q&A session, and I would like to invite all our speakers to join our panel. And it's my pleasure to invite Professor Dr. Nizar Ashmi, consultant, pediatric and oculoplastic ophthalmologist, to moderate the interactive session. Dr. Nizar, the floor is yours.
Thank you very much, Diva. Thanks for all of you. It's amazing. I learned a lot of things tonight. Thanks to ZEISS team for gathering us tonight. So I made it easy for me because I pulled a couple of questions that already asked in the audience. So I tried to distribute the questions, and myself, I have also a couple of questions. The first one is Miss Ripan, he was asking, or she was asking, is there any research on pregnancy, risk of myopia in children? What should parents do to avoid during pregnancy? So the solution, as far as I know, for example, in Europe, in my country, in France, we screen all the children. It's a mandatory to screen children between 9 months to 15 months of age. Dr. Shada, she made a good presentation where she mentioned that 0.5% of the newborn are myope. You have to know that we have 150 million newborn per year in the world. So roughly 6 million of children that born myope. So the only way is to, I think, to evaluate them and to screen them in the beginning. That will be one of the way, I think, to treat them. But as far as I know, but the door is open, the floor is open for everyone. There are no studies that prevent the baby to born or the mother to take any specific medication to avoid myopia. So that's first one. I answered to it. There's another question, and I think Professor Yazan will be the best person to answer to that. One of the person in the audience is asking, how can we be a good or trained good to be a myopia optometrist manager or care? So you are the professor of optometry to answer, and how you decide that this or that one will be a good one to take care of children. I mean, pediatric optometrist.
God, that's a very tough question to answer. Simply attend all the webinars that ZEISS and UF do, first of all. So if you follow up on, I think UF has a YouTube channel where everything is recorded. Correct me if I'm wrong, Connie. So I've started that journey with ZEISS 2 years ago, especially with Celine. And when I saw her, I saw the passion in her and her devotion to myopia management. So we agreed to go this path together. And actually, each webinar prepares the optometrist to go into that. I don't want to promote my myopia management guidelines that were supported by ZEISS, but if you can access them and have a look at them, they are also very useful in giving you basic step-by-step approach on how to manage myopia. And my advice would be read the literature carefully. Do not trust the propaganda and the promotion by the company itself. Well, be your own judge of the data first, and then start looking at the options and think of your patient first. We need to think of patient-centered eye care as supported by WHO. We don't want to, yes, we want to promote our practice, we want to make money, but at the end, it's the child's future and eye health that matters the most. And please, optometrists, collaborate with ophthalmologists. We cannot work, no man is an island after all, and with the narrow scope of practice in many countries, where, for example, you cannot do cyclorefraction, where you cannot prescribe atropine, the ophthalmologist is your best friend, literally, to manage patients in myopia management. I don't know if anyone would add more. Rashid, especially you deal every day with myopia cases at Bottle.
Yeah, I actually fully support and agree with all you said, Professor. I would add to it is don't be afraid to start. Because usually a lot of people are just very terrified to even begin to tackle such a huge topic. My advice to you is that do not be afraid to start. Start, and you will learn along the way. You need to have all the basics before. You need to study, you need to do your work, but do not be afraid to begin. Because once you begin, you will start learning new things. that will build already on what you have. But the most important thing, because honestly, myopia, it has become more than an epidemic. Like it's a global phenomenon that is increasing rapidly. So do not be scared to begin. That's my advice.
Thank you. I have another question for Dr. Liana. I have my own answer, but I want from the audience. They are asking you showed us how to decide between ortho-K and multifocal contact lenses. The general answer, you said what your patient accept is the best treatment.
Yeah.
Myself, for my fellows and residents, I say the technique in surgery or in medical you master the best as a doctor is the one to use daily. In my practice, I don't have orthokeratology. I don't master it. I loved your presentation, but I have to cope with my atropine and difocal lenses. So please let us know in daily situation, what would you go for, ortho or multifocal contact lens, and why?
Well, actually, to be honest, I said something very important in my presentation. I said if you want to go with ortho-K fitting, you really need to have a good lab consultancy, which unfortunately in Palestine, we have very limited access. Even scleral fitting is difficult here because the only lab is located inside Israel, and the technician that we communicate with does not have very good English skills, so there's a lot of obstacles. So for me personally, I've been prescribing either MySight or I know this is a ZEISS presentation, but we don't have ZEISS spectacles yet, but I'm doing Cooper Vision spectacles. It's very easy, and just to go with what Rashid and Dr. Yazan said, just start. It's very easy. If you're just prescribing spectacles, it's just like it's just like prescribing spectacles for normal myopia, except we have this special lens now that there are certain new measurements that we have to take. So I've prescribed MySight daily, and it was very simple, very easy. I prescribed it on pediatric patients between the ages of 6 to 8. So for me, it was just the most feasible option.
Thank you. I have two questions for my colleagues now, Professor Al-Mu'taz and Dr. Shada. So you have a 0.05 and 0.01 atropine in your hands. Both are available. Which one are you going to use? We have this discussion of that. There are two questions in one. From Europe, from Asia patient, there is this still controversy discussion. No, but the study were done mainly in Asia. And the second thing is, Dr. Al-Mu'taz, you said that accommodation and atropine is old conception, nothing there to be. So, but still my doctors, resident and junior, they think that we are giving atropine because we are blocking the accommodation in order to reduce the myopia. So you start first to answer, and then Dr. Shada to give us also her feedback, please.
No, ladies first.
As you like. I made it by gray hair.
No, whatever.
The floor is yours, Dr. Shada.
Thank you. Thank you for this opportunity to be amongst you here today. Well, I like to start with the 0.05 because it showed great evidence and less rebound and more effective and meaningful results with the 0.05. However, it's not available. So if given the options of 0.01 or 0.05, I would choose 0.05, but it also has a lot of factors depending on availability.
Dr. Al-Mu'taz.
Well, the case is easier here in Jordan because none of them is available commercial. So we have to prepare both of them. So that makes life easy. Now the studies say that well, first of all, let's answer the second question. Atropine definitely affects accommodation. Though why we are using the 0.01 or the 0.05 is because we try to optimize our concentration to get the effect that we want without affecting the accommodation. Especially that we're talking about school-age patients. Let's say that school-age candidates. If you affect their accommodation, that means you affect their school performance. This is not what we want to. So definitely atropine affects accommodation. The studies say that the 0.05% is the optimum concentration where you can get the maximum atropine effect that you want in delaying myopia progression with the least side effects that you can get. Definitely, you can get less side effects with the 0.01, but you will not get if I know that there are certain parts of the world. I used to work in Spain and in the States. You cannot prepare the atropine the way I presented it in this presentation. You cannot do that. You have to go to get it from the pharmacy. I tried personally here. I've been here for 30 years, and I've tried to commercially get atropine available in the market. And the issue is that you cannot, simply because it's not cost benefit effective for the companies. This is the bad point of it. We are here for one thing. We as optometrists and as ophthalmologists, we are here only for one thing, for the sake of our patients. So if I can get the best of the atropine that I want with the 0.05% without giving this poor young candidate, I will not call him a patient, the side effects, then definitely that will be my aim, especially that we are talking about a long-term treatment plan. We're not talking about a 1 month or a 2 month. Some people, those patients, they have been on myopia control for 10 years. We do not just put those patients off treatment. You have to follow up with them. So it's really what I like about ophthalmology is it's a lifestyle. You spend the whole time with your patients. You get them when they are 1 year, then 2 years, 3 years, and then you complete this journey for 20 or 30 years with them. So you have to talk with them as your friends, not as your patients. I hope this answers the question.
Yeah. So I have last question from my side to Dr. Peter. In short, complexity is the solution, what you said. So the more the lens is complex, the better it is. So you want to lure the brain. So you want to make it more difficult to adapt. That's what I understood from the M.O.V.E. So just tell us now, I have a child who is at the early stage, 6 years old, starting myopia, minus 0.5. What should I say to the family? Because I've been prescribing the care system for them for some times. What is the massive argument to tell to the family, not the scientific one that you exposed to us? What should I say to the family to start with this one in order to instead of the old one or the first one?
That is a great question. Thank you very much, Professor Neza. So, as you mentioned, I mean, if the patient is like 6 years old, this is basically what you expect, that the lens will be worn for the next, for example, 10 years, right? So this is the target of the M.O.V.E. technology, to really deliver the sustained myopia control over this extended period of times of wearing, and we've seen it in the care lens, we've seen it in other optical solutions, that basically after the 2 years you really see the lowering, of the efficacy rate. So if you will have such a small patient, you definitely need to go with the M.O.V.E. technology, because this is what the lens was designed for.
Okay. So in the idea of ZEISS, with 3-4 coming years, you think that we will be having the M.O.V.E. and the care at the same time, or we will be moving for good to the M.O.V.E.?
Well, I mean, as you can see, the pace of innovation is quite fast. So what will be in 3 to 4 years? This is very difficult to answer.
If I may jump in,
But maybe
allow
Celine
me
can, yeah.
to jump in. One point to mention is that the M.O.V.E. technology is right now already available. We got a pre-launch. The official launch is in October for most of the countries in the world. But because we are really involved into myopia management and doing studies and having many patients and working on a lot of medical education programs such as this one tonight, we already have the possibility to get the M.O.V.E. technology at ZEISS Vision centers and ZEISS Vision expert stores. Only in UAE for now, it's coming soon. The point that I want to say is that the price is the same, okay? We are a foundation. This is why we are doing all of this. This is why we were the first one being in Middle East. coming with a solution to slow down myopia. Even if everybody was saying myopia is not coming here, we knew it was coming. So whatever technology is coming, whatever improvement, fast improvement we can make, you can count on us to bring it to the region and to make it affordable, okay? What we have with MyoCare, and this is why from now it's going to be always available, is because we have the stock lens. And stock lens are exactly at the same price as any other stock lens from ZEISS. The M.O.V.E technology, because of the pre-launch, because it's completely new, is only an RX lens, which means that they are made on order in Germany, and so the cost is more expensive. So for now, you will have care all the time for sure. We are improving and we are working on the stock and the index and the power range and so on. But what we want to be sure is to make it affordable and available as soon as possible. Whatever solution we can bring to slow down this pandemic, the myopia. And just to finish on my side, I really wanted to thank all of you because, you know, building this type of webinar educational program around myopia is something quite tough in a way that we have new things, but we have the feeling we already know everything about it, you know, but actually we do not. And from the ARVO, last ARVO, but not only, every week, you have so many publications about combination therapy, about red light, about lenses, about everything that we need to understand. And I'm thinking about this question about how to be a good optometrist into myopia management. Stay aware and listen and look at what is happening everywhere in the world, on Chinese, on European, on Arabic children, everywhere. So always a lot to learn. So building this program was really a pleasure, and I really want all of us and the audience to thank all of you, because all of your presentations were really a very high quality. We all learned a lot. So from Peter, from me, from ZEISS, a big, big, big thank you for your participation tonight.
Thank you, and see you soon.
And thank you, Professor Neza, of course, but you're the best one managing a panel at the end. So, you know, it's not your first time, it's not your last time for sure.
And I love the talk of colleagues that I know, Professor Yazan, Al-Motaz, you already heard, and Dr. Shatya. You are working in Saudi Arabia. You know that I spent 2 years there. I will be happy to meet you in SOS, inshallah. Thank you very much, all of you.
Thank you all for the opportunity.
Enjoy your evening.
Thank you.
Thank you.
Thank you. Thank you. Have a good evening.
Thank you all once again to all our speakers, and special thank you to Dr. Nizar for expertly moderating the session. And Ms. Helen, would you like to share a few reflections on today's session?
Yeah, I just did. I'm sorry. I shortened the Q&A session, but I believe it's quite a little late tonight. But no, I said it all to everyone. What's coming up for us is definitely after summer. We have a big session at ESO. We are going to have 2 symposiums, very good speakers coming from China, and we are going into a new topic, which is dry eye. We are coming with a new solution. So very happy to see everyone at ESO Congress, and yes, SOS as well in Saudi. I mean, let's enjoy the summer and come back fresh, right?
Sure, exactly.
Thank you. Thank you, Swana, so and thank you, UF, always.
Okay, there's a poll and quiz questions. I think it's for all. We can take part in this.
Yes, this is important. If you can reply to these questions, that will definitely give us an idea of your practice, daily practice, and what do you do actually. So we can also adapt our medical program next.
Okay.
As we come to the end of today's webinar, I would like to extend my heartfelt thanks to all our distinguished speakers, moderators, and every participants who joined us today. A special thank you once again to ZEISS Vision Care for their continuous support and collaboration. We are delighted by the tremendous responses, and we got more than 850 registration from throughout the world. Just a reminder that this webinar carries 2 DHA CME points, and participant must have attended at least 1 hour of this session to qualify. Certificates will be issued within 21 working days. Before we conclude, I would like to invite everyone to join us 2 major upcoming events organized by United Optometrist Forum in Dubai. First is Icon 3, that is on World Sight Day. It will be a hybrid conference, 10th and 11th October 2026. 10th October will be an on-site event with a limited sitting capacity in Dubai, and 11th October will be a virtual throughout the world, anyone can join. And next, October 7, that is a celebration of the World Optometry Day here in Dubai in 23rd March 2027, but we are celebrating on 20 and 21, this 2 days on-site event in Dubai. Afterwards is one and only dedicated optometry conference in UAE, bringing together the profession to celebrate, learn and shape the future of eye care. Thank you all once again for your participation. Stay safe, stay inspired. We look forward to welcome you to our future EOF events. Good night. Thank you. Bye-bye.